Thank you everyone for joining and welcome to our call on telehealth and mental health. I'm Ariel Kane, the Director of Healthcare at PPI. Please feel free to send me questions during the call. My email is akane@ppionline.org. Fears about the novel coronavirus, the economy, and prolonged self-isolation are taking a toll on Americans, and it's making us sick. Calls to the federal mental health crisis hotline have increased 900% compared to this time last year. Telehealth provides an opportunity for Americans to access mental health and essential primary care providers from their home. Many healthcare providers, including therapists and psychiatrists, have adapted, moving their appointments from their office and meeting virtually. And there's evidence that telehealth provides benefits to patients with anxiety and depression. Virtual care can help people feel less isolated, learn coping tools, develop goals and routines, and provide emotional support for people struggling during this difficult time. And in bolstering mental health, telehealth offers a new way for improving patients' overall health. Today, I have here Neil Leibowitz, Chief Medical Officer at Talkspace. Talkspace is a medical technology company that provides online behavioral health treatment. In his role, he oversees the quality of care provided by clinicians on the platform. A practicing psychiatrist, Dr. Leibowitz teaches health law at Francis College in New York City, and is a healthcare quality improvement consultant and medical expert consultant to the New York State Department of Health. I also have Dr. Lucy McBride, a practicing internal medicine physician in Washington, D.C. For 20 years, she has focused on treating patients' physical and mental health in tandem. Since COVID-19 hit, Dr. McBride has published a daily newsletter to patients and is now reaching thousands of people around the country with real-time, fact-based medical information on getting through the COVID-19 pandemic physically and mentally. Thank you both for being here today. There's been a lot of conversation around telehealth and how it fits into the fight against COVID-19. Neil, can you give us some opening thoughts on how telehealth fits into our current public health crisis?
So thank you, and thank you for having me, Ariel. Before COVID, telehealth was all over the news, but really the utilization was a lot lower than you would think when you looked at how people were using it. In mental health, while it's really tailor-made for telehealth, utilization was low. There are some providers and networks like ours who are purely telehealth, but most providers either did it or didn't, and very few had any sort of hybrid model, and those doing it probably in the low single digits. After COVID, it became really the only way to access any sort of outpatient mental health. And by outpatient, it's not just that therapist visit, it became psychiatrist visits, it became people in day programs, it became people in methadone treatments, aside from picking up their methadone. So it expanded to really touching almost every person who's receiving healthcare treatment via mental health for telehealth. And what we've seen was really a huge surge of people, and the need has, just from our numbers, new people coming in for therapy have doubled in the last 8 to 10 weeks at this point. And what we're seeing from those people has been not only an increase in number, but an increase in acuity. So for the first time, when we measure outcomes and we track the severity of illness, for the first time in 9 years, we've actually seen a full deviation increase in the severity of anxiety people are coming in. And if you think about everything that's happened in this country in the past 8 or 9 years, we've never seen any increase, really nothing of statistical significance until now.
Thank you for that. And Lucy, I know in your practice, you've sought to integrate mental health and primary care. Can you give some opening comments on the state of mental health services in the U.S.? Oh, you're still on mute.
Absolutely, Ariel, and thanks for having me. This is a great opportunity so as you said, for 20 years, I've been working with patients, and I've found that when we integrate a conversation about mental health into the primary care setting, and we weave it into a conversation about whole health, not only do we help people feel better, but we actually improve medical outcomes. There's data upon data to show that when we address grief, loss, trauma, depression, anxiety, substance abuse, and basic behavioral components to people's health, we actually can improve health outcomes. And so, as you know, this pandemic is not just about coughs, fevers, and the coronavirus itself. It is also a pandemic and a crisis of mental health. So telehealth has offered this wonderful opportunity to increase access to my patients. I'm able to reach them in their homes, and I'm able to use my skills that I'm already using with them, but formerly in person, to address their very acute, as Neil said, needs. The calls I'm getting every day from patients are indeed about coronavirus, and I have many patients with the virus and who are sick, most of whom are recovering. But the majority of calls I'm getting right now, particularly as we face re-entry and the fear that comes along with that, is about depression, anxiety, difficulty staying sober, difficulty with grief and trauma. And so to be able to help people with these things now in their homes is a real asset.
Yeah, building on that, a new study came out this week that estimates that the COVID-19 pandemic could lead to 75,000 additional deaths in the US from alcohol and drug misuse and suicide if the country fails to invest in solutions that can help heal the nation's isolation, pain, and suffering. How could telehealth help mitigate the mental traumas from COVID? And then Dr. McBride, do you want to answer that one?
Sure. Well, for one thing, access for many people to mental health services is difficult. If you think about it, to see a therapist, to attend an AA meeting, to go to a day program, or to meet a psychiatrist de novo takes time off of work. It takes transportation. It takes the ability to have someone available in your area. And so telemedicine, particularly if we were able to expand access of internet services to a wide reach of the population, we could really, really increase the ability for people to get the services they need. And not only would it increase access, it can augment services. So people who can't take the day off of work to see their therapist or go to their AA meeting could then do it. So it would really, really, it already has offered a substantial improvement in services we can deliver. And I should say this, while there's still no substitute for in-person communication and that sort of personal community, but some people cannot simply get it to a doctor, not to mention a mental health provider, with ease.
And Neil, you had mentioned that even though telehealth, we've read about it for years, there hadn't been huge uptake prior to now. Why hadn't it become widely used?
A couple of reasons. First is always people's hesitancy to try anything new. Mm-hmm. That's always been sort of a grounded piece. Also, medical professionals are generally not at the forefront of trying something new either. So we generally wait until we do. The technology's been there. It's actually been, I've been doing telehealth probably for 8 or 9 years. It's gotten much better over time. So it's less about the technology. And then the other piece has always been that there are definitely hurdles and roadblocks that need to be navigated from both a federal and state level and from a payer level that have made it complicated. And a lot of people say, why bother? Telehealth has actually been around since the early 1900s. We call it the telephone. And people have been communicating with their physician for over 100 years. It's never been called telehealth because no one's ever been paid for it. So having a mechanism, A, to do it safely, legally, confidentially, HIPAA compliant, and having a way to get paid for work that you're doing. I would have never asked Dr. McBride to sit on the phone with me for a half hour previously because she wouldn't get paid for it.
And it's so much of what primary care providers like myself deliver is counseling, education, sort of the connecting of the dots between people's social determinants of health, behavioral health, habits. A lot of my job is about a dialogue, about a relationship. And, there's no way to do a physical exam over the phone. There's no way to do a physical exam or like to feel a breast mass or to examine someone's lymph nodes over the phone. But what I'm moving to more and more, and this is here to stay, is the ability to do a large part of my work, which includes mental health services and mental health, recognition of that component in people's whole health, is moving that part to video and virtual platforms because we can, and because it increases people's ability to get them. And then it actually augments services. I was able last week, for example, to have an end of life conversation with a family who were in their home, the patient in his bed, who would not have been able to make it to my physical office even pre-pandemic. And to be able to have that conversation while not ideal and to not be in person was actually very, very meaningful and productive.
And then I know that because of COVID-19, both the Trump administration and many states have taken steps to make it easier to access telehealth services. Neil, can you explain what's happened so far and if it's enough?
Oh, I'm going to touch on some of the things. There have been many, but I'll touch on the highlights. And I think the response has been from both the federal and the state level has been phenomenal. At the federal level, many of the Medicare, for example, requirements have been temporarily suspended. So things such as now telephonic, you can now receive remuneration for. That's probably something that we want to move people to a HIPAA compliant down the road, but that's definitely a great measure because not everyone has access to broadband. Not everyone's great with a computer, especially as you think about that Medicare population. The rates have had parity of rates for telehealth. So that's a very high value for providers, for physicians, for clinicians who generally have seen at least a 30% drop off in their patient base right now. And for some, it's a lot higher. So definitely cutting their rates and cutting volume would be a very hard pill. So that's been wonderful at the federal level. And waiving of the scope in terms of allowing it really for everyone. At the state level, what they've done, and waiving the licensure, the state licensure at the federal level. States individually, many have also waived the state licensure. And what I mean by state licensure is under telehealth, I, as a New York State licensed physician, can only see a New York State resident. Now, if we think to the bricks and mortar, it didn't make a ton of sense all the time anyway, because my bricks and mortar, I could see someone from New Jersey who worked in Manhattan, but I can't see them via telehealth. But waiving that really to meet the pandemic, and I'll use New York as an example again, but many, many states have done very similar things. In New York, any US licensed, and they actually added Canada in, can see a New York State resident right now. And that's not just for mental health, that's for medical care, mental health care, really any care that can be performed virtually. So that's been really a high value to promote access at a time of need. And many of, as Ariel had mentioned at the outset, many of the people giving the care have adapted. They've moved to both telephonic, they've gotten on things such as a HIPAA compliant Zoom, and have adapted really to meet the needs of the populace at this point.
And someone just emailed me questions, so I'm going to read it to you guys real quick. But what are the public policy and legal obstacles to a more widespread use and adoption of telehealth for mental health services? I think that sort of builds on, so what has, they've done a lot of things in the short term, but what still remains?
So, I guess.
Go ahead. I'll answer after you.
The highlight to me is still that this interstate will sundown, and we're going to be left with the access issue that was previously. So there are high need states that don't have enough therapists. And within that, that's group one. Even in states that may have a lot of therapists, many may be out of network. So really expanding that global access becomes very valuable. Additionally, mental health is different. I think we touched on this, and Dr. McBride said it nicely earlier, it's a little different than some of the medical procedures. A lot of people now put their toe in the water for help, and for the first time, they're seeing a therapist. Or maybe for the first time, they're seeing a therapist that they bonded with. What generally happens, and even in seeing the transition from office-based to virtual, we've seen a 30% drop. When you think about, well, we're going to now tell someone who for the first time is doing well, and maybe that therapist is from Kansas, who's changed their lives, and they're sitting in Maryland, that you're probably going to have to change therapist on September 1. The discontinuation rate will be enormous. And then the other piece is that while I sometimes am an optimist and I'm trying to be optimistic about the overall health of the nation in terms of the severity, I am optimistic we're not going to have a crisis of suicide. I'm optimistic that substance abuse won't be increasingly prevalent if we react. I do think mental health tracks economics very closely. So while for medical, we're going to come out of this hopefully 1 month, 2 months, 3 months, but there's an end date. We might not see it yet. The economic problems are going to linger for quite some time. One of the interesting things that I've spoken about internally with some of my colleagues, with my CEO, has been we thought by now some of the mental health might flatline a little bit in terms of the growth. We're actually seeing more growth in the last 2 weeks and more people coming in looking for help than we did at the beginning of the pandemic. Because I think the economic realities for a lot of people are starting to set in. And as things open, they're going to set in. This is the first time I've actually seen doctors take a hit like this, lawyers take a hit like this. It's not just the people at the margins of economy. So really promoting anything that promotes access is going to be the #1 need right now.
I totally agree, Neil. And just piggybacking on what you were saying and expanding a little bit, I too am an optimist. I have hope. I have, my patients give me hope every day, the ones who are recovering beautifully from coronavirus. The patients who are reaching out to me and asking for help with, or sometimes not asking for help with their mood and grief, and then do take that first step and get help with a therapist they had never had a relationship before, and then find that it helps their mood and their anxiety and their sleep. But I do think that as people face this new reality, we are going to have an uptick in mental health service needs. And one of the things I think that it's essential for removing barriers and to increasing access is insurance companies liberalizing their and increasing their coverage of payment to mental health providers. So one of the biggest barriers I see in my patients who want mental health services, or who I'm trying to convince that they need, is that they can't find someone in their network, particularly in urban centers. I'm in Washington, D.C., but it can be very difficult to look in your network and find someone who takes your insurance. And then, unfortunately, the reimbursement rates from insurance companies can be so low for these mental health providers, who in my mind are what I call the muscle of my practice, or essential workers for patient care, is so low that they can't afford to stay in business, or they have to see people in short time frames, or they have to live far away from urban centers to be able to afford the rent. And what would be wonderful is if there was more recognition from insurance companies and our federal government of the importance of mental health as a key component to whole health, particularly as we face what I see as a second wave of mental health distress, which to me is going to then just unleash, physical health distress. I mean, as I was saying earlier, post 9/11, for example, when we had a collective trauma, the 3-year increase in cardiovascular morbidity, mortality was notable. There are many studies to show that the trauma, emotional trauma, affected people's, literally their medical outcomes. And I see that every day with my patients. But even without anecdotal evidence of me telling you this right now, we see this borne out in other collective trauma experiences in this country. And so I think we need to be very, very careful that we address and remove any barriers to people getting the essential mental health services they need more than ever to bolster our economy by having people healthier. I mean, I think, when people are healthier, the economy does better. When people can work and feel safe and not get sick at work, the economy is better. And then the whole kit and caboodle improves. I mean, that's where my optimism will sit.
Something that I've been thinking a lot about is, we've heard a lot about the digital divide with students who, if students don't have a home internet connection, they are not, able to get the information from their teachers right now. So how does that play into, the people who may need the most mental health or the most assistance, or could be the people who also have, limited access to either health insurance or connectivity, where you might be able to access a therapist for a cheaper amount. So I don't know if anyone wants to talk about.
Well, this is where Ariel, I think we need to talk about, in conjunction with other policy changes as it pertains to, paying for services, is we need universal broadband. We need everyone in this country ideally to have internet access. I actually wrote a piece for the Washington Post with Reed Hundt, who was the former FCC chairman under President Clinton, about this mandate, which it's been talked about for a long, long time, but now more than ever, as doctors and therapists and psychiatrists and essential healthcare providers are pivoting to telehealth, we need to get our country wired up to be able to receive services. I mean, wouldn't it be great if in the future you could reach someone in rural America who had a physical disability, who had never thought about his or her mental health, to not have to drive somewhere to get mental health or physical health services, and to get at needed, help with his or her depression, diabetes, and that sort of holistic type care in the comfort of their home. I mean, that would be, and the thing is, it's possible. It is absolutely possible.
I'm going to piggyback just a touch, just from timely, as I happen to have a board call this morning with a large FQHC in the Bronx that serves an underserved population. We moved to telehealth. We picked a vendor that was HIPAA compliant in about 24 hours when this started, which was great. Only 20% of their visits are occurring via video because their clientele does not have the ability from an access standpoint to use the technology. So we were actually talking about how to move people over, because we know that we're going to sundown the telephonic at some point, and it should be. That's a good thing, because you need at least eye contact at some point. But how do we get the fact that we're 80-20 telephonic for this cohort? How do we get them to at least be 80-20 the other way? So it's not just a rural issue. There's a huge urban component as well.
Well, and this is something you would know more about, but I know that some people are more likely to have a smartphone than they are to have a landline with internet connection. So, so that's also something that needs to be factored in, is that apps may make more sense in the future. Well, so my next question, we already sort of touched on, but how do you think we can use this crisis to change how we think about and deliver mental health services? So how is mental health delivered via telehealth different than other types of care? And how will these, changes continue past COVID?
Well, I think we touched on that a little bit already, but just to emphasize that, mental health services are actually perfectly designed for telemedicine, in that it's about a relationship and a rapport. And if you can have eye contact and better access, then you're really, really doing well. And I think for the first time, so many people in this pandemic are realizing, who never did before, that, wow, my mental health actually matters, and I feel vulnerable, and I'm now more inclined, now that I see it in the news and I hear about more access, that I need this component to my healthcare. So, and I think as Neil was saying earlier, telemedicine has always been around. It's just now starting to be paid for, and it is not going away. It is going to be part of the new normal. It's going to be bundled into the way I practice medicine, because it is increasing access, it's augmenting services. And so now we just need to figure out how to access people in their homes and how to get it to everyone who needs it.
The other interesting point, and people who haven't done telehealth have told me this, but it's something I've known for years, is my no-show rate on virtual visits is 1% or lower. Mm-hmm. There's less stigma. We think maybe where I live or some of you live, stigma is pretty low. I think in some areas of New York, if you're not in therapy, you're shunned. But for many, stigma is still alive and well, and especially for people with trauma. They're much less likely to go to an office. Every move to walk into that office, there are 100 reasons not to go. And what we've found, what I've seen both at Talkspace and in my personal practice, has been that people show up. The confidentiality, the distance yet the familiarity is very valuable. And there's a huge value add there. I'm not for removing office-based treatment. I think it should exist. And I think for some people can do only virtual. I think some people can start with their evaluation in person and move to telehealth at their choice. So it's going to need to incorporate. It's not going to look the same for everyone, but there are huge swaths of the population that will only get their mental health care at a distance because it's so different. There's no stigma in going to a doctor to look at your arm if it's broken. There's no stigma if you're coughing to go to an office. Those things are all going to go back to normal. So it becomes a value add service and something you can offer people to help save time. For mental health, it's an integral part of people seeking service.
I think that's an excellent point. I mean, I see so many people, like I said, who are my patients that I've been urging to engage in mental health services, who know very well that my sort of mantra in healthcare is that mental health matters, yet have been walking around for years with a card of a therapist with like frayed edges in their pocket and have never taken that step. But when it's in the comfort of their own home and there's that distance and that sort of ability to just click off if it's not going well, which it inevitably does go well, people feel less vulnerable and more likely to access. And so, that's very hopeful for our future.
And then we're just about out of time, but do you have any closing thoughts on, what we can do around increasing access, whether it be from a federal perspective, you had mentioned insurance reimbursement, just, how I think we are making progress and how do we kind of continue to push that progress forward?
I mean, one thing I'd like to just say is that I think, as we re-enter and reopen the economy, what is clear to me is we're going to need an army of frontline primary care providers more than ever. I mean, as you probably know, a huge, staggering number of Americans do not have a primary care doctor. And right now, more than ever, we are being asked, at a very granular level about how to make decisions that directly affect people's, health and well-being. And so, I look forward to a future where primary care doctors can, be available to everybody, but also understand the importance of mental health and have the ability to weave that into their practices. And so that's my hope for the future. And I see mental health being integrated into our culture as progress for the whole person.
And a little bit more abstract is how I think, which is one, how do we drive choice and access and relationships? Those are really the key to a successful mental health system. So if you're in Alaska and you're a Muslim woman looking for a Muslim therapist, probably good luck. So how do we, and the bond that you create with that therapist is very valuable. Maybe you find that Muslim person in Alaska, but then your husband relocates to Virginia. What do you do? So those are the questions. Those are things that I've dealt with both on the personal level and on a corporate level of trying to do that. And the most heart-wrenching customer stories to me are, why can't I continue with my therapist? I moved, but I've been working with them for 3 years, and they're not interested in hearing the regulations. They're interested in understanding, well, you're ruining my life. Now I got to start again. And how do we avoid those type of things? And I think that dovetails with primary care is very similar.
Continuity matters. It very much does.
Well, thank you both so much for your time. We really appreciate it. We'll put this online and so people can access it there. And then please feel free to send any follow-up questions and we can pass them along. Thank you both. Stay safe and
Thanks for having us. Yeah.
I know we don't really have real schedules anymore, but have a good Memorial Day weekend.
Okay. Thanks, Ariel.
Might look like.
Take care.
Thanks, everybody. Bye.